Hello, everyone. Thank you for joining today's webinar. Dr. Jamil Kazma will now begin the program.
All right, thank you, Nikki. Good afternoon, everyone, and welcome to today's program. It's Case Conversations, Alternative Routes of Tranexamic Acid Treatment and Obstetric Bleeding, which is basically the WOMAN-PharmacoTXA trial. My name is Jamil Kazma, and I'm one of the fourth-year residents at the OBGYN department at the George Washington University School of Medicine and Health Sciences in DC. And I'm joined today by my mentor, Dr. Ahmadzia, who is the associate professor with the Division of Maternal Fetal Medicine at the George Washington University, and Dr. Monica Arribas, who's a research fellow and the senior trial manager and faculty at the London School of Hygiene and Tropical Medicine. Next slide. So the Foundation for Women and Girls with Blood Disorders mission is to ensure that all women and girls with blood disorders are correctly diagnosed and optimally managed at every life stage. To this end, we aim to provide education to healthcare providers on the medical consequences and unique issues for women and girls with blood disorders. Since its inception, the foundation has focused on realizing its vision through these objectives, as you can see displayed. To ensure the best sound quality during our program, all attendees will be muted. However, you will have the opportunity to participate in a question and answer session with Drs. Arribas and Ahmadzia at the end of the program. You can submit your questions during or after the presentation portion via the chat box in your control panel on the right-hand side of your screen, and we will address them during the QA session at the end of today's presentation. The next few slides detail our accreditation process in support of improving patient care. This activity has been planned and implemented by ScienMed and the Foundation for Women and Girls with Blood Disorders. Continuing education credits will be provided, and a follow-up email will be sent to attendees explaining how to obtain 1 hour of CME CE credits for the program after its conclusion. This activity is being provided independent of industry support. These are the learning objectives for today's event. The first objective is explain differences between intravenous, intramuscular, or oral tranexamic acid for prevention of postpartum hemorrhage at the time of delivery. We will also be discussing safety of using tranexamic acid for mother and neonate in the peripartum period. We also will be exploring future studies that will evaluate efficacy and safety of tranexamic acid at cesarean and vaginal delivery of postpartum hemorrhage prevention. All provider employees in control of content have indicated that they have no relevant financial relationships to disclose. Speakers with financial relationships to disclose are noted. All attendees will receive an email an hour after the program's conclusion with evaluation and the link to claim your 1 hour credit. The accreditation overview is also available as a handout. And so before we begin, we would like to do a quick poll to see how many people are joining us today. With others, please take a moment to answer the poll questions on your screen. Awesome. We would also like to ask a few questions to assess your knowledge before the presentation today. Okay, and the second question is, when should TXA be administered for treatment of postpartum hemorrhage? And we have one more question. Is there data from large randomized clinical trials that show safety concern for seizures or thrombosis with TXA use? All right. Well, thank you all for your responses. I will now turn the slides over to Dr. Arribas for the presentation.
Thank you, Dr. Kazma, and thank you to the Foundation for inviting me to show our work on the WOMAN-PharmacoTXA trial, looking at alternative routes for tranexamic acid treatment in obstetric bleeding. Oh, sorry. Tranexamic acid is a synthetic analog of the amino acid lysine, which binds plasminogen on its lysine binding site. In doing so, it prevents fibrin binding to plasmin. In this way, fibrinolysis is inhibited and the blood clot is stabilized. Tranexamic acid is marketed in a tablet and injection form as a treatment for a variety of chronic and acute bleeding conditions. It's affordable, it's easy to store, and it's easy to distribute. At the London School of Hygiene and Tropical Medicine, we have been looking at the effects of tranexamic acid or TXA for the in postpartum hemorrhage. The first trial was the WOMAN trial, which was published in 2017 and recruited 20,000 women. This trial was looking at tranexamic acid for the treatment of postpartum hemorrhage. The WOMAN-2 trial is currently still recruiting. It has recruited more than 14,000 participants so far, but the target is 15,000, so the target will be achieved very soon. It's looking at TXA for the prevention of postpartum bleeding in women with anemia. This audience may be interested in a paper that has been very recently published looking at the relationship of maternal anemia and the risk of postpartum hemorrhage that has been with data from this study, and it shows that anemia is strongly associated with the risk of developing postpartum hemorrhage and the risk of death. Today we are going to talk about the WOMAN-PharmacoTXA trial, and then as well at the end we will mention the IM-WOMAN trial, which is going to be looking at the TXA by the intramuscular or intravenous route for the prevention of PPH in women at higher risk. This trial is currently in setup phase. An estimated of 100,000 women die from severe bleeding after giving birth every year. And we know from the WOMAN trial that early administration of IV tranexamic acid cuts the number of deaths by 1/3. Time is critical, first because many women die in the few hours after the bleeding onset, and as well because for every 15 minutes of treatment delay, there is a 10% decrease in the survival benefit, up to 3 hours where there is no benefit. Based on this evidence that comes from the WOMAN trial, the WHO recommends the early use of IV TXA within 3 hours of birth in women with postpartum hemorrhage. They also state that research on other routes of TXA administration is a priority. And on this line, the recently published roadmap to combat PPH states that the top priority for the innovation track is the research on the comparative effectiveness and safety, of alternative routes of tranexamic acid administration for the treatment of PPH. We need to study alternative routes for the administration of TXA. First of all, because the administration of the IV injection is a main barrier for the rapid treatment. Medical personnel trying to insert intravenous lines may be not available when the birth happens in areas far from the clinical settings or in understaffed hospitals. And this is relevant in low and middle income countries where many of the PPH deaths happen before the woman reaches hospital. So if administration of the TXA solution orally and intramuscularly is shown to be safe and can achieve therapeutic levels, this would allow the rapid treatment of women with PPH at the hospitals and in the community. To look at the different routes of administration, we are going to look at the pharmacokinetics. Pharmacokinetics can be defined as what the body does to the drug. And in this case, we're going to be looking at the concentration of TXA in blood over time. We know from previous work that the concentration at which TXA inhibits the breakdown of the blood clot is between 10 and 15 milligrams per liter. And in this study, we investigate if TXA given by oral and intramuscular route first reaches the therapeutic concentration needed to block fibrinolysis, and then if this, how long does this take? This has to be early enough to be useful for women with PPH. So we are comparing the oral, the IM, and the IV route, which is the standard route of delivery. When we decided to look at alternative routes of TXA administrator, we started a pharmacological program with different studies. The first one was the trauma intact study that recruited 30 patients with bleeding trauma. And this study showed that IM TXA is well tolerated and rapidly absorbed, and the therapeutic concentrations that are just above 10 milligrams per liter are reached within 15 minutes. The PharmacoTXA trial with 15 healthy volunteers in France look at the IV, IM, and oral TXA. The results of the study show that the oral TXA is absorbed slowly. It takes more than 1 hour to reach the therapeutic concentrations, but in the IM route, the therapeutic concentrations are reached within 15 minutes after administration. All the routes were well tolerated and there weren't any serious adverse events. So having done these studies, why is necessary a trial to look at the tranexamic acid pharmacokinetics in pregnant women? First, to look at the safety of the woman and the neonate. And then because all these physiological changes that happen during pregnancy that may impact the pharmacokinetics of the drug, such as higher fibrinolytic potential in pregnant women, higher circulatory plasma volume, and faster renal clearance. And this is particularly important because we know that TXA is excreted in the urine. The WOMAN-PharmacoTXA is a randomized open-label trial. It recruited 120 adult women giving birth by C-section with at least one risk factor for PPH from Zambia and Pakistan. Women were randomized to receive either 1 gram of TXA IV over a 10-minute injection, 1 gram of TXA IM in 2 5-milliliter injections, 4 grams of TXA as an oral solution. This was 40 milliliters to drink, and no TXA. The dose for the oral group was selected because a previous study gave 2 grams of TXA to the participants, but this took about 3 hours to reach the therapeutic concentration. So this is why we decided to increase the dose. And it was given as a solution instead of tablets, just to facilitate the absorption in the gastrointestinal tract. The primary outcome is blood TXA concentrations over time, and the secondary outcomes we have safety outcomes, such as the adverse events in the mother and the neonate, local reactions at IM injection sites, and neonate status and Apgar score. We had as well blood concentrations of D-dimer over time, TXA concentration in the umbilical cord and in the neonate after birth, and blood loss and clinical diagnosis of PPH. This table shows the baseline characteristics of the participant in this study in the 4 arms. It's a summary, they are not here, but you can look at the paper if you're interested. This is the IM arm, IV, oral, and no TXA. The important thing here is to realize that there are not substantial differences in the characteristics of the participants across the 4 arms. Received TXA about 1 hour before C-section. The PK samples were taken using the Mitra device from a finger prick. You can see here a picture of the Mitra cartridge. This technology was validated in one of our previous studies, and it proved really useful when we needed to send samples from the hospitals in Zambia and Pakistan to France, where they were analyzed for the pharmacokinetics. The maternal samples were taken at baseline and at 8 different time points from 15 minutes to 24 hours. And then we had samples from the umbilical cord just after cord clamp and neonatal samples shortly after birth. The TXA concentrations in the blood were measured by liquid chromatography and mass spectrometry. And then there were as well some blood samples to assess the safety at baseline and after 24 hours of randomization. Regarding the maternal safety, no serious adverse events were reported. There were some cases of nausea and vomiting in the IV group. We have 2 of nausea, 2 of vomiting, 2 of nausea in the oral, and 1 in the no TXA group. There were as well 2 cases of dizziness in the IV group. This wasn't reported by anybody in the IM group. Nausea, vomiting, and dizziness, these are known side effects of TXA. Importantly, there weren't any seizures, any vascular occlusive events, or any other adverse events reported. This slide shows the TXA blood levels over time. The dotted line is what we can call the therapeutic concentration of 10 milligrams per liter. And we have here the intravenous, intramuscular, and oral groups. So what we can see here is that the intravenous TXA, just after administration, has a peak really quickly in just a very few minutes, just in a few minutes, it can achieve around 46 milligrams per liter, and then it starts decreasing. The dark blue line is the median, and the shade in blue is the 90% confidence interval. In the intramuscular group, we can see that the therapeutic concentration, the time is in hours, so the therapeutic concentration is achieved really quickly, before 15 minutes. And then it keeps increasing up to a concentration of around 20 milligrams per liter. This happens at 49 minutes, around 49 minutes in the modeling, and then it comes down in the period of the 24 hours. And in the oral group, what we can see is that the therapeutic concentration is not reached until about 1 hour after administration. Then the maximal concentration in blood is reached around about 3 hours, and then it's sustained and finally decreasing. This slide shows the simulated maternal D-dimer concentration versus time. I wanted to show this slide just to talk a little bit about pharmacodynamics. D-dimer is a product of the breakdown of fibrin and can be used as a pharmacodynamic marker. And we have here, again, the median in dark blue, and then the shade is the 90% confidence interval. This is the no TXA group. D-dimer increases during pregnancy, during childbirth, and as well during the cesarean section. And so this is the no TXA group. And what we are looking here is that at the inhibitory effect of TXA on the generation of D-dimers. And I just want to show that here in the intravenous group, this is the intravenous and this is the intramuscular, there is good inhibition of the D-dimer generation. The intravenous and intramuscular groups are very similar. There is some inhibition as well in the oral group. It starts later and there is less inhibition. I'm not going to talk about this together with the pharmacokinetics. Let us estimate the IC50 around 7.5 milligrams per liter. So it justifies that the therapeutic concentration just above 10 milligrams per liter would be effective. This study didn't have the power to assess the efficacy of TXA in reducing or having any effect in the maternal blood loss. However, the data we have allows us to see some trends. There was no clinically diagnosed PPH in the IM group or the IV group. There were 5 cases in the oral group and 3 cases of PPH in the no TXA group. This is the total estimated blood loss at the time of PPH diagnosis. In the oral group is 2,100 milliliters and no TXA is 1,200 milliliters. There seems to be some difference in the intraoperative blood loss. So the IM group and the IV group are quite similar, and it's higher in the oral and the no TXA group. But you cannot really see any differences in the 2-hour postoperative blood loss or the total blood loss. So we would need a much bigger trial with many more participants to be able to talk about efficacy. In the neonate, there were no serious adverse events reported. There was 1 stillbirth in the oral group, and there was a case of multiple congenital abnormalities in the no TXA group that led to death as well. But both these cases were present before entering the trial, and they weren't associated with the trial intervention. There was no significant difference in birth weight across the groups or in the Apgar score. In conclusion, intramuscular TXA is rapidly absorbed. The target level is reached in about 10 minutes, and it's safe for the mother and the neonate. The administration of the IM TXA can be very fast. The oral solution is slowly absorbed. The target level is reached about 1 hour, around about 1 hour, and this may be too late to treat PPH. In an emergency situation, it can take time to place an IV line, and then there is the 10 minutes of slow injection time. And so the pharmacokinetics profile of the IM route is a favorable alternative to IV administration. And now the next step would be to run a large randomized clinical trial to learn more about the clinical efficacy of the IM route. And this is the IM Woman trial. And I will talk a little bit about it at the end of these presentations. Thank you. I would like now to invite Dr. Ahmadzia to share the optimum OB TXA study.
Thank you so much, Dr. Arribas.
Sorry, very important. Nikki, can I get control of the slides again? Thank you. I almost forget. This study is funded by the Bill and Melinda Gates Foundation and by the Wellcome Trust. And these are the collaborators that work in this study in Pakistan, France, Zambia, and at the LSHTM. Thank you. I'm sorry.
No problem. No, that's very important to acknowledge all the team members involved in the funding source. So thank you so much. I think this is a really fascinating article and segues very nicely to some of the work that I've been doing at our institution and in collaboration with other mentors across different institutions. So the Optimum OB TXA trial stands for the optimal timing, route, and dose of tranexamic acid prior to umbilical cord clamp for postpartum hemorrhage prevention. So I wanted to take a step back just briefly to kind of highlight how staggering the disparities are on a global platform when you look at maternal mortality ratios or rates across the world. You can see on the y-axis is the maternal mortality ratio, and on the x-axis, different countries across the globe and regions specifically. And you can see the difference is several hundred when you compare certain regions. And I think this is particularly important, and one of the reasons I'm so passionate about doing the work that I'm doing in maternal health and obstetrics is my family is originally from Afghanistan. And I think maternal health issues in that region, especially in Africa and other parts of the world, where there's limited resources, is critical to finding alternative and good solutions. So another sort of way to make this more personal, I think the topic in the sense that this was an experience, a picture of a hospital I was at in Mulago Hospital in Kampala, Uganda, and they do about 20,000 deliveries a year. It's a large tertiary hospital, and this is one of their 2 operating room theaters for that volume of patients. And you know, if a patient had a hemorrhage, blood tests would be difficult to obtain or delayed. If a patient needed a blood transfusion, you know, that would be very challenging. And oftentimes in low resource settings, families asked to go find donors for the blood. And so I think it's so critical to look at preventative strategies like tranexamic acid. I wanted to highlight briefly, many of you may have heard of, or if you haven't, it's important to be aware of this study that recently came out in the New England Journal. The Maternal Fetal Medicine Unit Network trial. There's over 11,000 patients were randomized in several centers across the US, and they gave tranexamic acid at the time of umbilical cord clamp for prevention at the time of cesarean delivery. And you can see from the figures here that their outcomes of maternal death or blood transfusion and blood loss greater than a liter showed a trend towards a reduction with tranexamic acid compared to placebo. However, I think it's important to know that this was given at umbilical cord clamp, right? So when you're at a C-section, there's obviously bleeding before that time, and sometimes it can be 15, 20, or even 30 minutes, depending on the patient's body habits or scar tissue until the baby's delivered. And sometimes minutes can be a lot, sometimes even hundreds of cc's when the placenta separates and you have a brisk source of a bleed. So this is also, I think, quite interesting to set the stage of why this is an important topic. There's conflicting opinions in our current resources and references in terms of when to use it. There was a New England Journal of Medicine article that came out about 2 years ago that suggested really we should be using it when the blood loss is over 1,500 milliliters, which is quite high, I think, and a little on the later side, in my opinion. And then up to date, a common clinical reference suggests that using TXA before the skin incision at the time of cesarean appears to be more effective based on the studies, smaller, albeit to date we have. And then even for high-risk patients, their suggestion is to consider it with oxytocin as a preventative strategy. So I think in terms of what are we currently doing and looking at national data. This was a recent extraction about 2 months ago from Cerner real-world data. So hundreds of hospitals across the US and over millions of pregnant women, pulling over the last 5 to 10 years, when are we giving TXA with respect to timing of delivery? And about more than 15% of the time, we're actually giving it prior to delivery, which, according to our polls at the beginning, several of you have had some experience doing that even. And so I think this underscores the importance of looking at efficacy when giving TXA pre-cord clamp, a bigger trial, because we haven't systematically collected all the data, I would say, from these newborn outcomes, from the maternal outcomes, because most of the studies are at cord clamp at this time because of the theoretical concern to the neonate. So I would sort of make the point here, and the prior slides, as well as Dr. Arribas, I think segue nicely, say there's some questions still. What about vaginal delivery, right? More than, in the US, at least 70% of women have vaginal deliveries. And so most of the studies to date have been in cesarean delivery. And what if you give it an hour before and you time the delivery wrong, right? You think the patient is going to deliver, but they don't. So do you need to redose, and when, and things like that? So that's important. Morbid obesity in the United States, that's really important in other high resource settings and other low resource settings where this is a challenge or issue, and specifically with respect to perhaps underdosing. If we're giving a medication and saying the same dose should work for everyone, but the volume of distribution or overall circulating volume is much higher in patients with BMIs of greater than 50, for example, I think we could be not seeing an impact when perhaps we're underdosing them. Then I think specifically with respect to the timing or how we give the medications, I should say, is the IV push over 2 minutes, for example. Some of large French studies looked at giving it kind of more quickly, which they showed was safe in their studies, but not quite what the drug label says is typically used. Or IV infusion over 10 minutes. That's most commonly done based on the drug label. However, in a lot of settings, even in the US, we don't have an extra infusion pump or a nurse who can protocolize that and monitor that. And so more rapid administration, if safe and sufficient, providing the targets, would be probably preferable in all settings, I would say. And then intramuscular, we've talked about already, so critical in low resource settings. And patients who actually may not want much intervention are looking for home births and not looking for access IV and so forth. So when is really the optimal timing to give TXA for prevention? I think that's what our study with the Optimal OB is also focused on, and looking at a follow-up pharmacokinetic and dynamic study when giving TXA right before umbilical cord clamp. And we're trying to see if a lower dose can achieve therapeutic levels of TXA in pregnant women who are randomized to receive this, both undergoing cesarean and vaginal delivery. And specifically, we're looking at different groups, which includes IV over 2 minutes, and as well 10 minutes, and intramuscular routes. We're looking at a no drug group for comparison, specifically because cesarean delivery and delivery itself can cause an increase in clotting factors and biomarkers. And then the BMI greater than 50, as I alluded to, is a special interest because we want to make sure we're sufficiently having the appropriate dose for these women. Some of our methods are based on prior published work, which I've referenced here, in terms of the methodology of how we determine the pharmacodynamic target. I'll just highlight our PK target was similar in that the minimum was 10 micrograms per milliliter, or milligrams per liter is the same in terms of units. The pharmacodynamic target used maximum lysis, which is a parameter that looks at the lysis portion of a clotting test, using rotational thromboelastometry, or ROTEM for short. It looks at the physical properties of whole blood and a coagulation machine. And you can see on the curve there that I've illustrated, that's where you have excessive lysis. And for example, if you had tissue plasminogen activator, TPA, and we use that to spike our samples, you get 100% maximum lysis. And so what we do is we have a pre-drug sample and then 8 time points over 24 hours, look based on the different half-life and routes of administration. And we have in vivo administration, as I mentioned, And then we're monitoring both the pharmacokinetics and dynamics over time using both the blood levels for the TXA concentration and then the RO10 parameters. In addition to pharmacodynamics, we will plan to do D-dimer levels, as Dr. Arribas mentioned, and correlate that with our findings, as well as thrombin generation and plasma generation assays. Now, I don't have results to show you quite yet. We've enrolled about 15 patients so far, but I wanted to make an important point here from other large meta-analyses and systematic reviews looking at what is this question or risk of thrombosis, right, when using tranexamic acid. And so this was probably the best study to date that's been published from JAMA surgery. And you can see in over 125,000 patients that were included in 216 trials, they did not see an increased signal in thrombosis or thrombotic events for TXA versus placebo. Now, this is important because it's its comparison group is well chosen. It's a randomized trials that are included and not cohort studies. And that if you say, well, the patient got TXA and had a higher risk, they might have gotten it because they were sicker or having bleeding issues. And so that is very important to have a randomized assignment and analysis for that. Interestingly, if you had increased risk for vascular occlusive events with a prior history, for example, or excuse me, if you had a history of prior thromboembolism or a clot history, you would think, well, maybe that would show a signal, but it didn't in this large meta-analysis. And most of the patients included here are often older, have more comorbidities, and undergoing things like heart bypass surgery or orthopedic surgery or liver transplant surgery. So I think it's also important that you can't perfectly translate to obstetrics, but they are have a baseline higher risk of morbidity to begin with. And then what about the potential risk for seizures? This is something that you really need large numbers to kind of assess. And this is one of the best studies to date. Again, a systematic meta-analysis with over 102,000 patients that did not show an increased risk of seizures with tranexamic acid when compared to placebo. They did look in a sensitivity analysis when looking at the doses of TXA used in trials. If more than 2 grams per day was used, there was a slight signal seen there. However, it's important to note in the obstetric population, especially with the landmark woman trial, 1 gram was the standard dose, and then a maximum of the 2 grams if the patient was continuing to bleed. So this is something we don't anticipate seeing in our pregnancy population. It is important to follow up and look at this subgroup too. And so I just wanted to acknowledge all the team members who've helped along the way with the work that was funded by the K23 that I alluded to, and future work that I'll be doing, as well as the clinical trials and larger efficacy studies I hope to be involved in. So thank you. And then finally, just to put a brief plug and related work that I think is important to kind of acknowledge is united efforts to reduce global obstetric hemorrhage, and it's a advocacy / research / networking platform, I would say, and our next session is October 16th. So I thought this audience might be interested. We have some wonderful speakers all across the world speaking. Thank you so much. And I'll turn it now over back to Dr. Arribas to touch on the IM Women trial.
Thank you very much, Dr. Ahmadzia. I will briefly speak about the IM Woman trial, which is, as we said before, it's on setup phase. So this is a large randomized clinical trial that is needed to learn more about the clinical efficacy and safety of the IM route. This trial will look at the TXA by the intramuscular and intravenous route for the prevention of postpartum hemorrhage in women at increased risk. It's a randomized trial and is placebo-controlled. The founder is Unitate. It says in the title that the trial is for the prevention of PPH. In this study, TXA will be delivered. So we will have women that have both either C-section or vaginal deliveries. They can be included in both cases. And in the case of C-section, the trial drug will be administered after dropping. And in the case of vaginal delivery, the trial drug will be delivered at crowning. The objectives are to assess the effect of TXA on the risk of PPH and other bleeding-related outcomes. We want to compare the IM and the IV route, both for efficacy and for safety. So we want really to see if the IM is as good as the IV route. It's a non-inferiority trial, sorry. And it is a randomized placebo-controlled 3-arm trial. We will recruit in hospitals in Africa and Asia. And it will be women giving birth vaginally or by C-section, as we said, with one or more risk factors for PPH. And the intervention is IM, and the comparators are IV TXA, 1 gram, or placebo. And the sample size is 30,000 women. The primary outcome is clinical diagnosis of primary PPH. And you can see here the secondary outcomes, surgical and postpartum blood loss, in other interventions for bleeding, adverse events in the mother and the neonate, and then days in ICU, length in hospital stay, death, and neonatal outcomes. You can follow this trial and other trials by linking to this website. I think this will have been saved in the foundation page. If you are curious, you could log in and you could subscribe to our newsletter to learn more about these studies. And I just wanted to thank you for listening, and thank you as well to thank all the doctors, nurses, midwives that make possible these studies. I think this is my last slide. So Dr. Kazma, I will hand now the slides to you.
Thank you so much. Thank you, Dr. Arribas and Dr. Ahmadzia, for your informative presentations. Before we move on to the QA sessions, I would just like to, we have some knowledge questions that we want to ask to see the kind of like knowledge gained during today's presentation. So I'll ask Nikki to share the first question, which is, when should TXA be administered for treatment of postpartum hemorrhage?
Oh, fantastic.
And we'll move on to the next question. Is there data from large randomized clinical trials that show safety concerns for seizure or thrombosis with TXA use? Okay. All right, so at this time, we will proceed with the question and answer part of our program. As a reminder, the participants can submit questions via the chat box in your control panel. And I'll just start asking the questions as they come in. I'm gonna start with my first question, looking at the oral TXA, Dr. Arribas, because you mentioned that in your presentation. I feel like in patients from a clinical perspective, when we see patients who are at high risk of postpartum hemorrhage and we expect them that are going to have an excessive blood loss, would let's say, and we are like implementing ERAS protocols for like recovery and surgery, would oral TXA be an option for these patients to be given like 2 hours before their scheduled C-section? And would that be, because I know it takes 2 hours for it to reach pharmacokinetic levels, And have there been any studies about that oral TXA specifically?
There have been studies in the past. I don't recall a study for prevention in surgery, if that is what you are asking. It would be possible to give it, but I think it is more, if you, the IM route, I would use the IM route for that type of case, because so the IM route is sustained. After 2 hours, you will still be above the therapeutic concentration for sure. It's easy to administer. Like in this trial, we administered like an hour before the C-section. It was actually between 1 hour plus minus half an hour, but it did work in the pharmacokinetics and the pharmacodynamics. The tablets you can have difficulty swallowing. These participants drank 40 milliliters of solution. It would be I think for prevention, the IM route would be the best. As well, the IV route can be used, but the IM route didn't show any of the side effects with that the tranexamic acid usually have: nausea, vomiting, and so on. This is because the peak takes longer to be reached, but still you have a good concentration quite quickly that would cover that period. And just to ensure that all the patients would have that needed concentration of tranexamic acid, because we wouldn't be sure, I think, with the oral TXA that would be achieved.
Awesome, thank you. One question from the chat is, can you comment on what the umbilical samples for TXA levels demonstrated in your study, Dr. Arribas?
Sorry, can you repeat the question?
Yes, it's can you comment on what the umbilical samples for TXA levels demonstrated in your study?
Yes, so that was very interesting. So we collected the samples just after cord clamp, and we look at the tranexamic concentration. So the tranexamic acid crosses the placenta. This was known before. In this study, I haven't shown the figure. It's in the paper. It shows that about the concentration in the neonate is about 52% of the concentration in the mom. So that's the average, but it does cross the placenta. But half-life of tranexamic acid is very short. It's just 1 or 2 hours. So it will be eliminated from the system quite quickly.
Thank you, and that's a good segue kind of for the other question. So following an IM administration of TXA, would you repeat the dose of TXA, either IM or PO? And if so, when would you repeat it? How long does it last therapeutically in the blood?
Well, yeah, we can look at it lasts up. So the therapeutic level, it lasts for a few hours above the therapeutic level. So it is just, so 1 gram, this is going back to Dr. Ahmadzia presentation as well, because 1 gram tranexamic acid is the standard dose that is given. Our trials are pragmatic trials. This is the dose we have tested. It has a very good safety profile. There is no risk with this dose. And so it is, you know, it would last for a few hours. Now, in the WOMAN trial, 1 gram IV was given. If the woman continued bleeding, the doctors in charge of the patients could administer another gram of TXA. So this is at the discretion of the clinician. I don't know if Dr. Ahmadzia wants to elaborate on this.
Sure, yeah, I'd love to chime in. So in terms of the repeat dose, I guess to say how long does it last, maybe I'll answer that a little bit, is when we did our original study of looking at pharmacokinetics of pregnancy, we had looked not at 1 gram initially, we looked at 5, 10, and 15 milligrams per kilogram with a maximum of 1 gram. And in a cohort of 30 women who received varying doses that I mentioned, all of the women had sustained concentrations above the 10 microgram threshold per milliliter for at least 45 minutes after delivery, which really is the highest risk period in a cesarean delivery, at least in a vaginal delivery as well. So in terms of repeating a dose, you know, if you're using the 1 gram, I think most of the guidelines that currently we use are based from the WOMAN trial because of the ongoing bleeding, and that's how it was designed for treatment. When it comes to prevention, I think I'm hoping some of the work we're doing with the follow-up PK/PD work currently we'll get some better estimates of the duration of action, or then when do you potentially need to repeat a dose if you were going to repeat it with ongoing bleeding and timelines. I think some of that information will be helpful, especially if in a vaginal delivery, right? As I mentioned, if you gave it, I don't know, an hour and a half before or something off with the timing, when are the levels too low? I think that's an important question. And I know a lot of perhaps people on the call, if they're considering women who have you know, a factor 11 deficiency or hemophilia A or B carriers, and sort of what do they need extra dosing or preventative dosing? I think those are also important questions that we'll hope to either answer with our follow-up study or maybe a combined analysis, which we're working on trying to do that. And so with the pharmacologic dosing.
Yeah, there's a lot of stuff that need to be like teased out still about use of TXA, especially with prevention instead of treatment. One other question we have is, does TXA prevent both primary and secondary postpartum hemorrhage? From a clinical perspective, Dr. Ahmadzia, if you've noticed that.
Yeah, no, thanks for that question. So in terms of most of the data, I would say when we look at prevention, it's for primary postpartum hemorrhage. The main studies being you know, I would say the TRAP and the TRAP2, they were all focused on the prevention side. WOMAN-2 is prevention, and these are the largest ones. There's certainly smaller ones that are looking at prevention, but they're all really targeting that primary postpartum hemorrhage within that first 24-hour period. The secondary postpartum hemorrhage, I would say there's probably less robust data looking specifically at that in terms of especially clinical trials or randomized clinical trials. Again, getting back to the point of women with bleeding disorders, I think this is where it becomes really important. Like when, for example, von Willebrand factors start dropping at 7 to 10 days or 2 weeks out, I think that's when they're the highest risk period. And so the challenge there becomes is when it's a rare condition, how do you get the numbers you need to really show that efficacy in the prevention side? But I think it's an important question. And if until we can make those bigger trials, hopefully possible, or if that is not on the horizon, then I would argue that it's a risk-benefit ratio. And if we're not seeing harms with the use of preventative TXA use in that postpartum period, then it makes probably sense, especially if the risks are much higher with a patient with a strong bleeding history.
Yeah, thank you for that. I don't see any other questions in the chat. I had a quick question about like, how would you differentiate between treatment of like postpartum hemorrhage in vaginal deliveries and C-sections? Because we know in C-sections, you would have bleeding not just from the uterus, but also from like going down to get the uterus and like taking care of the adhesions, or you nicked some of these perforating vessels in the fascia or the subcutaneous tissue. And I feel like giving TXA at the cord clamp kind of like would not help control the bleeding before that. And it's kind of different to assess when do we start counting the blood loss as postpartum hemorrhage?
Did you want to, Dr. Arribas, feel that, or I can chime in?
Well, by definition, postpartum hemorrhage after the baby is born in both cases, but in the WOMAN trial, for instance, we differentiate with the intraoperative blood loss, which will be recorded, and then we collect the information the 2 hours after birth and then up to 24 hours. So in this way we can see, but I know what you mean, because the moment is considered postpartum hemorrhage 50 500, the magical 500 milliliters in vaginal deliveries and 1,000 in C-sections, which include the surgery. So, but yes.
Yeah, I actually was thinking while you were talking a question. I'm curious if you all at the sites were enrolling for the WOMAN-2 trial. Have you found any of the patients there, or providers, I guess, maybe are saying maybe we can't randomize this patient because we really want to give her TXA preventatively, so we can't randomize her? Like, has that come across yet or not yet?
In general, with the hospitals we work, TXA is not given for prevention. In general, there are some sites that for some cases, they give it for prevention. Placenta previa, these type of cases that they are quite sure that the woman is going to have a high bleed, and this has come up. But our sites don't give TXA for prevention for PPH in general. As I say, sometimes it may be given, or yeah, this is what they would do. But then this woman wouldn't be randomized, or if they have many cases, in this case, the hospital wouldn't be included in the study. So yeah, but it's not very common in Africa. We're working in Nigeria and Tanzania, and then in Pakistan, and we haven't had many cases at all.
Yeah, no, thank you for adding that. I feel like we, clinically in the United States too, have this question, preventatively using, and I think I tried to make a point that we're kind of still, some of us are using, some aren't, but if we don't kind of do this larger even clinical trial in the US, I think it's also a critical window or time that if you get to a certain point where people are using it more routinely, it becomes harder to complete those studies, or even potentially we're not getting the safety data on the neonatal side, right? Or is it maybe preemies are higher risk, and we need to look at that. But right now, I think is a unique opportunity. So hopefully this foundation pharmacology work will lay and segue nicely into the findings for the I Am Woman trial and future efficacy studies in high risk.
Yes, I agree completely about, if many sites, many doctors prescribe tranexamic acid prophylactically for PPH, then it can become an issue for the recruitment of participants. Hopefully this won't happen, at least when we are running the I Am Woman trial. As well, it's very important to run the trial. So I know people are prescribing it, but because you give it prophylactically, you have to make sure it's safe, because you are going to give the drug to a number, possibly a huge number of women, and you need to make sure that it's absolutely safe for the woman and the baby.
Yeah, so, actually that reminds me of the last poll question, which I think we got 50-50, almost split of the response. I think the data I showed, maybe the reason the sort of different take homes was the data was non-pregnancy specific, right? So I think we do have good large randomized trials and systematic meta-analyses and reviews, but maybe not in the specific population that we're talking about. And I do think that is the next step too. So hopefully that will be done.
Awesome. So that is all the time we have for questions today. Thank you for this wonderful discussion and for the presentations, Dr. Ahmadzia and Dr. Arribas. The foundation is pleased to provide this program at no cost to attendees. For the participants, you will receive the evaluation following this program in your registration email in about an hour, along with the link to claim your continuing education certificate. A recording will also be made available by the end of the week. All registrants will be informed once this is available. Thank you all for your attendance today, and we look forward to your future participation in foundation programs.